really is a privilege to have the opportunity to speak with you today. Often laser talks are amongst dermatologists, and to have the chance to get the word out about what we do to you is really wonderful. So my background, I'm a dermatologist. I'm affiliated with George Washington University, and I also work at Children's specifically to treat kids who may benefit from laser therapy. So I don't see general dermatology. I specifically do laser therapy. It says that I have no disclosures. Actually, I was thinking I do have a patent application on one laser, which I'll be telling you about. So the conditions that most commonly present for treatment are vascular lesions, pigmented lesions, angiofibromas associated with tuberous sclerosis, and in the end, I'll speak briefly about scars, which is a very exciting area in lasers right now. So when a child presents for laser treatment, it's a real window of opportunity. Kids often just do much better if they're treated early. Some reasons for this is the skin is thinner, lesions are smaller. However, obviously kids can't cooperate with laser treatment, so it's always a balancing act, trying to get the best improvement, but balancing that with the comfort of the child. So I'll speak briefly about how lasers work. So I find it fascinating that you can take a laser, which by definition is one specific wavelength of light, and target something in the skin and completely leave everything else untouched. So this concept of selective photothermolysis was developed by my mentor, Dr. Anderson, and basically, without boring you with all the physics, there's three components. You need a wavelength that has preferential absorption for whatever you're targeting. So for the vascular lesions, that's going to be hemoglobin. Pigmented lesions, it'll be melanin. An appropriate pulse duration, which is how long it takes to deliver the energy, and an appropriate fluence. So after this, you'll see a lot more pictures, but the distinction, first I'm going to talk about vascular lesions, between an infantile hemangioma and a port wine stain is something that a lot of people confuse. In fact, I get a lot of referrals from dermatologists who use the wrong terminology. So I want to briefly go over the differences. Hemangiomas, you may see something subtle at birth. They typically appear within the first few weeks of life, and they proliferate. They get bigger, and then they slowly involute. They're GLUT1 positive, and they're an actual tumor, although they're benign. A port wine stain, in contrast, is present at birth. It never regresses. It can become thicker. It's GLUT1 negative, and it's a malformation. So with regards to port wine stains, these really benefit from early referral. So if you see a kid with a port wine stain, feel free to email me or someone that you know who can treat these, because it really gives a huge advantage. While these kids do while anyone with a port wine stain can get better, right now only about 20% clear completely. And there was a recent study showing if you initiate treatment at 6 months of age or before, you can get about a 90% average clearance. So this is a picture of a baby that I began treatment at 6 weeks of age, and after 4 treatments, he's almost clear. This is an interesting picture because it almost looks like a fading capillary malformation, but in this case, the color, the sharp contrast of the borders, and the asymmetry really favored port wine stain diagnosis. So right now, the pulse dye lasers are the gold standard. They're really safe in well-trained hands, but they don't work 100% of the time, so it's exciting that there's a lot of research and a lot of alternate technologies that are being looked at. The Alexandrite and the ND-YAG laser, they're longer wavelengths, so longer wavelengths go deeper in the skin. That also has a higher risk of scarring. There's also a vein-selective laser, which I've done some in vitro research with Dr. Anderson at Harvard to look at. And some interesting work on anti-angiogenesis medications, both topically with imicamod and orally with rapamycin, as well as photodynamic therapy. So this is just briefly to show you how, if you look at the various wavelengths of light, there's oxyhemoglobin, which is in blue here, and then there's the deoxyhemoglobin, which is in pink. Traditionally, we've gone after oxyhemoglobin, but now there's more awareness that a port wine stain is actually made up largely of venules, and deoxyhemoglobin may be worth targeting. And in terms of the anti-angiogenesis medications, the thinking here is for a long time, we didn't realize why lasers were not completely effective. Well, in part, they stimulate the injury to the skin, which causes hypoxia, and in turn stimulates angiogenesis. A vein-selective laser is something that's being worked on. The theory being, if you clip off arteries in the skin, it's almost like a heart attack for the skin. You cause necrosis and scarring. So if you can go after veins, it may be safer and more effective. It's important to recognize syndromes. So Port Weinstein in a V1 distribution, this child actually has multiple dermatomes affected, but should be screened for Sturge-Weber syndrome, which can have associated glaucoma, seizures, and developmental delay. Klippel-Trenaunay is often missed. This is an obvious case, but if there's a Port Weinstein on the leg, it's important to see if there's any limb length discrepancy or hypertrophy of the lower extremity. If you talk to these kids, I had a teenage boy recently who had this and didn't realize it. They don't play sports. The only sport this kid did was swimming because they have pain, and a simple orthotic can actually really change their lives. So if you see a red stain, it's not always a Port Weinstein. This is actually a picture from a textbook of a superficial hemangioma. A salmon patch or a fading capillary malformation can also look red. An early AVM can look just like a Port Weinstein, but it's warm and you may feel a pulse. And interestingly, recently there were reports of early localized morphia when it's red being mistaken for Port Weinsteins. So this is the reason that we treat these kids in part. No one's ever done the study to show does laser prevent hypertrophy. This is a patient of mine, but you can see she's got these little vascular blebs. She's got, her left cheek is significantly larger than her right cheek. And in fact, most Port Weinsteins actually do hypertrophy. So about 65%, and it happens later in life. But again, if you can treat a Port Weinstein early, most experts agree that would prevent this hypertrophy. So moving on, you can see this is a newborn with a stain on the cheek. And I'll just take a poll of how many people think it's a Port Weinstein versus a hemangioma. How many think it's a Port Weinstein? And what about a hemangioma? Okay, you guys are far better than dermatologists when I give this lecture, but yeah, yes. So in fact, this is subtle at birth. However, it's a precursor to a segmental hemangioma on the cheek of a baby girl. And on the pictures on the right is at 4 months of age. So infantile hemangiomas, really common, and most of them do fine. Most of them don't need treatment. However, more recently, we're realizing that it's not just the hemangiomas that are causing functional difficulties, obstructing the eye, the ear, the ones that are bleeding or ulcerating, but also there's a cosmetic component. While most of these eventually go away, there's a social component to having this when you go to kindergarten, and many of them leave behind textural change or a color change. So it's always a balancing act between which ones need to be treated. This is a slide showing some complications, obviously any affecting the visual axis or ulceration. These are clear indications for treatment. There's no clear protocol or guideline. Here are some of the options. There's some topical treatments. Intralesional steroids can be implemented. Systemic treatments, steroids, and then more recently propranolol. Laser has a role, not for all hemangiomas, and it's a bit controversial for certain ones in surgery. So what's the role of laser? Ulcerated hemangiomas, I think it's a pretty clear indication. Works about half the time and can be really miraculous for some ulcerations. Involuted hemangiomas that are done, yes. Proliferating lesions or ones that haven't yet involuted, I think there's a real question mark there. So this is a baby that actually Dr. Norton sent me. She had, I saw her this month, an ulceration for 2 months. She'd been on mupirocin for 2 months, and anytime she was held on her thigh, this is her thigh, she was in pain. And I looked at her, she was skin type 5. Generally, darker skin patients are harder to treat with laser because you worry about pigmentary issues, but this was going to scar anyhow. So at a very low fluence, a single pulse of the laser, she healed within a week. So many ulcerated hemangiomas can do quite well. Then the question is, does early treatment of an infantile hemangioma help? I would say the answer is not clear. There was a randomized control trial that was published in The Lancet about a decade ago, which did show pulse dye laser does seem to cause compared to no treatment, did show early clearance of the hemangioma, but at a year, the differences, really there was not much difference, and there were some side effects, probably because there was no cooling on these lasers. So a recent retrospective case review looked at a bunch of hemangiomas. They did see a significant improvement with pulse dye laser and minor adverse effects, but the average number of treatments here was about 6 or 7 and using pretty high energies. This picture is important to note, though, because in my opinion, it's these superficial hemangiomas that can often do well with laser. The mixed ones or deeper ones, I think, are much more challenging to treat with laser. This shows what can be left behind, the color change and textural change. And more recently, there have been these non-ablative fractional lasers, which are these lasers that basically create a pixelated pattern of energy and create an improvement without the same downtime we used to see. And you see before and after, how much the atrophy and textural changes improved. So this is my baby. When she was 6 weeks old, she popped up with this vascular lesion. And my mentor at Harvard had said, you know, if you get these things really early, you could probably stop them from growing. So I said, okay, let me treat this with a laser. It went away. And actually, this is a study that's ongoing at Harvard, a very early treatment before 3 months of age. So it'll be interesting to see what the results are. It went away in my daughter, but I don't know what it would have been. It did look like a hemangioma precursor. So briefly, propranolol is really changing the landscape of treatment for hemangiomas. In the past, for complicated hemangiomas, corticosteroids were the first line. Now there's some studies looking at steroids versus propranolol to see which is better. But propranolol, most hemangiomas do seem to respond, and many quite quickly. There are some potential side effects, but well monitored, appears to be quite well tolerated. Since propranolol works, the thought was, why not try timolol, a topical ophthalmic solution? And there was a review of 73 patients. This is relatively new. There have been no randomized controlled trials as of yet. And in these 73 patients, all got better except one, and a mean of about 45%. So I'm just going to move on to a few other topics. So spider angioma is very benign, but quite common, and often do bother the parents more than the kid. Can happen spontaneously or from trauma. These are very easy to treat with a laser. Angiofibromas are an interesting story associated with tuberous sclerosis. Laser was the gold standard until recently. However, there have been reports of topical rapamycin. If you can get it covered and compounded, it really works quite well. And that in combination with laser is probably where we're going, a combination of pulse dye lasers and CO2 lasers. Nevus of Oda is a brown or gray patch that appears usually unilaterally. It can appear early in life, and there's a second peak around puberty, and this actually responds quite well to Q-switch lasers. A Becker's nevus is a tan patch or minimally elevated plaque, often with coarse hairs. This picture's on the face, but the classic story is on a teenage boy's shoulder. These can really bother people aesthetically. However, they're quite challenging to treat, so I'll only initiate treatment if someone's very, very bothered by it. Café au lait macules can respond to treatment, although it's variable and they may recur, but worth trying again if it's in a disfiguring location. So congenital nevus, this is a garment-type congenital nevus, and laser is definitely not first line for congenital nevi. However, if you have a congenital nevus that is very disfiguring and not amenable to surgical resection, some laser surgeons will consider treatment. And the concern, though, is that you are not treating the full depth of the lesion. So you can create a scar and mask the deeper component, and these intrinsically have a risk of melanoma. So the concern would be that you're masking the appearance of a melanoma. Other concerns are, could a laser induce malignant transformation? That has not been reported. But again, this is controversial, but some people will treat these with some success. So I'm not going to speak a lot about scars, but this was a picture in a publication by Dr. Donnellan, who works at the Shriners, and his colleague, Dr. Parrott, in Boston, who I have had the chance to work with when I was a resident, and he does amazing work. And this is one example of a kid who had a flash burn from gasoline and what pulse dye laser can do in terms of the color and the texture. And now, again, it's combinations of lasers are really being used to help burn scars, color, texture, and hypertrophy. And in terms of anesthesia, it's really a broad range of approaches. In my opinion, no anesthesia is appropriate for a very limited number of pulses. Sweeties can be used in infants. Topical anesthetics, though we have to stay below the package insert guidelines, and I would never apply a topical to an ulcerated lesion because there have been a few reports with EMLA and methemoglobinemia with that. And general anesthesia in a healthy kid, typically at 6 months of age, is when we will start treating. And I do treat children in the operating room at Children's. So in conclusion, real pleasure to talk to you today, and just want to get the word out. Many conditions really respond best when they're treated early. Port Weinstein's in particular. Hemangiomas are best referred early. There's a vascular anomalies clinic at Children's. It's probably the best place to send the hemangiomas, and I'm happy to be emailed with any questions. Thank you.
We have time. Pardon me. If there are any questions around use of lasers in children? Any comment on tattoo regrets? Regrets?
Oh, so, there's actually a company that, I don't know what its status is, called Freedom 2, that was looking at these easily removable tattoo pigments. So my comment is that's what we need, because, you see people, they get their boyfriend's name tattooed and then they break up with them the next week. So yeah, there's a lot of tattoo regrets. Pencil tattoos, you guys probably see the pencil tattoos, those can respond, when the kid gets jabbed with a pencil, those can actually respond nicely to a Q-switch laser. Yeah, and tattoos, we can treat tattoos.